Ladies and gentlemen, my name is Stefan Doldi and I'm coming from Germany, and it's a pity I have to speak English tonight, and my English is not the best. It's a bit rusty. It's from the late 70s, and I beg for pardon for it, but I can't change it right now. What I'm going to do doesn't have any claim for being a scientific lecture. It is just a presentation of what cardiac imaging can do today. And as I know from this morning, the possibilities in Varna are mostly better than at some hospitals in Germany. They have a technique, equipment which is great, and when you make your medical education at Varna, it has been a good idea for sure. Okay, so here we are. Theme is cardiovascular imaging today, and now you see why I can afford to be here. More than 50% of mortality worldwide is caused by ischemic cardiovascular diseases. That's why I'm here. That's why I can afford the study fees for my son. But that's the reason for our politicians and for our economists that they want to decrease this amount of deaths. It's very, very expensive, but it pays my salary, so it's okay right now. What kind of different heart diseases do we have? We have the ischemic heart disease, heart attack, heart infarction, rheumatic valvular heart diseases, inflammatory heart disease, cardiomyopathy, and hypertensive heart disease, and others, congenitals or something. And today we talk about ischemic, valvular, inflammatory, and these two. So what is to evaluate? To evaluate for a cardiologist is the thorax. This is the thorax. These are the bones, and this is the heart. These are the vessels, blue, the veins, red, the arteries. This is the aorta, this the vena cava, and this is to evaluate. And in the heart you see 4 chambers, right and left atrium and right and left ventricle, and the valves in between. The heart is a muscle which works 60 to 80 times per minute, every day, every year, over 70 to 90 years, so long as you live. And this is a very high amount of energy the heart uses, and the energy must be transported to the heart, and that goes over the coronary arteries. On the right-hand side, you have the RCA. It's Latin. Normally it's Latin, but in English it's right coronary artery. On the left-hand side, the main branch here, and afterwards the LAD, or ramus interventricularis anterior. LAD means left anterior descendant, or the ramus circumflexus. I think it's called circumflex artery, isn't it? Okay. What imaging tools do we have? We have an X-ray. We have the echo. Does anyone know what echo is? Echocardiography? Yes. Thallium myocardium scintigraphy, cardio MRI, cardio CT, and coronary artery angiography. Sorry, but the most important what we doctors have and what we should use is our sense. So our eyes, our hands, and our ears. Without the clinical examination, there is no technical examination necessary. But every examination has different sensitivities. A normal ECG in angina pectoris, angina, has a sensitivity von under 50%. So if a person has angina and goes to a doctor and he writes an ECG, it only has a sensitivity von less than 50%. As stress ECG is a bit more, laboratory 0, echo 50, stress echo 60 to 80, cardio MRI is 98, and the angiography, the heart catheter, is about 100%. So you should think of what you are doing during your examinations, and of course you start with an ECG, but you should know it only has a sensitivity of less than 50% if it's not a myocardial infarction. So what risks for heart diseases do you know we can change? Does anyone know a risk for a heart disease? Yes?
Smoking, drinking.
Smoking, drinking. Smoking, you are right, completely right. Smoking is horrible, and smoking pays my salary. It's great. I like smokers. And over 90% of people who are lying in my cath lab are smokers or have been smokers. So it's great. I love them. Go on with it. Drinking is not right. Drinking is fine. Drinking isn't really a risk for coronary heart disease, but for others, for the muscle. It's not for coronary, just for the muscle. You can get a cardiomyopathy by drinking too much. That's right. Hypertension. Yeah? Diabetes mellitus. Hyperlipidemia. The weight, immobility, infection, for example, for cardiomyopathy, and the other risks we can't change are, first of all, your gender. If you are a man and you go to a urologist and you want to become a woman, it doesn't help. Because genetically you remain a man, okay? Men have a bit higher risk to get a heart attack than women. Your age is a risk. A person over 70 has a larger risk than a person over 15. And your genetic disposition is very, very important. That means that one of your family, your father, your sister, your mother, had a heart attack, has bypasses, had something, then your personal risk is about 50% to get a heart disease as well, a coronary heart disease as well. If you smoke additionally, or have a diabetes, or have hypertension, or hyperlipidemia, you can tune up your personal risk up to 100% to get a heart attack in between 10 years. So there are some stages of coronary heart disease. The first one is you have no pain, but we see an ischemia in ECG or stress ECG or echo or something. The next one is what we call a stable AP, stable angina. You get angina always when you are doing something, climbing stairs, going up to a hill or something. If you do that, you always get angina, then it's called stable. The third one is the unstable angina. It's the new angina, the first new, or if you get it always, when you are climbing, when you're having a rest, when you are sitting in your bathroom, whatever, yeah, that's unstable. The fourth one is the acute coronary syndrome. We have two stages, what we call the NSTEMI, the non-ST elevation myocardial infarction, or the ST elevation myocardial infarction. The ACS, the acute coronary syndrome, is an infarction, okay? What symptoms do we have? We have pain, and in Germany we say the heart is a chameleon because the pain can be everywhere. We had heart attacks with pain in the right arm, with pain in the teeth, with pain in the abdomen, without pain. We had everything. And so we say a heart attack is like a chameleon. What do you have else? You suffer from dyspnea, perspiration, of course. You have stress, much stress, sickness, vertigo, something like this. But if you had a heart attack once with a definite kind of pain, your next heart attack will be nearly the same. So if you had pain in the left arm and you get another heart attack in 3 years, you will probably get pain in the left arm again. This is what we see in your arteries if you have a coronary heart disease. On the right-hand side, this is a scheme. You see the what we call plaque in the vessel. It's mostly LDL cholesterol, what is in your vessel, and in several years it gets calcificated, and that's what we call a calcificated coronary heart disease. And this is a preparate of such a vessel. You see the fatty streak here in the middle of the vessel, and you can feel that it makes the vessel narrow. And what you see here is a coronary endoscopy, and you see this is normally the vessel, and this is a thrombus in this vessel, and you see this is the rest of the lumen we have. So this patient gets pain, that's for sure. Okay, what can X-ray do? X-ray can not really do very much in coronary heart diseases, but we see the configuration of the heart, we see the dimensions, we see a bit of the pericardium, we see sometimes a valve calcification, we can see the lungs, the bones, the diaphragm, and parts of the abdomen. But it's not really much. On the right-hand side, normal X-ray of the chest. On the left-hand side, what is it? Pulmonary edema, congestion. The heart is a bit too large. You see, if you compare these two hearts, the lungs are white, and what you see here, the white parts of the lungs is edema. It's water. What can echocardiography do? Echocardiography is beautiful. It's non-invasive. It's cheap. It's fast. And it's very, very, very nice because we see very much. We see the anatomy of the heart, the myocardial function, the wall function, the kinetic, the movement, the valves, and in and extracardial masses. What we see here is insufficiency of a valve. It's the aortic valve. You see the aortic valve is here, and the insufficiency, the banner of the insufficiency is here. Do you see it? Yes, you do. This is a mitral insufficiency. Left atrium, right atrium, left ventricle, parts of the right ventricle, mitral valve, and this is the mitral valve insufficiency. It's severe. This is tricuspidal valve insufficiency, left ventricle, left atrium, right ventricle insufficiency. Okay, what we see here is the aortic valve stenosis. This is the preparate. You see the typical Mercedes star, what we say in Germany. It's like a Mercedes star. You see it's tricuspid, the aortic valve, and you see the typical Mercedes star, but you see the calcifications at the borders of the valves. And in echo, you see this. It doesn't open, it doesn't really open, it's calcificated. And the heart, the left ventricle has great problems to pump the blood through this calcificated valve. What we see here is a bicuspid aortic valve. Sometimes it is genetically, sometimes it is congenital, but sometimes it's calcifications because it's a calcification of the former tricuspid valve and it gets bicuspid. But mostly all of the bicuspid valves have to be operated in later times. The patients get problems. This is a mitral valve stenosis, and insufficiency, you see the left atrium, the left ventricle, here's the mitral valve, you see the calcifications, you see that the valve isn't able to open smoothly, and a light insufficiency here, and this is another perspective. You see the valve can't open and has to be operated. Okay? This is what we call a mitral or tricuspidal prolapse. Does anyone know what this is? Any women, for example? No? Ladies have that very often because the valves of young ladies are a bit weaker than of men, so young women in puberty have this, and you see the prolapse of these two valves, the prolapse in the left atrium. Normally it's not a severe disease. Normally it's it doesn't matter, but if it gets a severe prolapse with a big insufficiency, it has to be operated later as well. So what we see here is a left ventricular thrombus in echo. You see the masses here in the apex. This is the left atrium, the right atrium, left ventricle, and you see here a a leak of wall movement in the apex. This person had an infarction of the anterior wall, and if the anterior wall or any wall doesn't pump rightly, people sometimes get a thrombus inside of the left ventricle. And what is in what kind is it dangerous to get a thrombus in the ventricle? The problem of these persons is a stroke. The risk to get a stroke. What kind of medicine do they have to take? Yeah, they need an anticoagulation, for example, with Marcumar, Fenprocoumon. Okay, MRI. The basis of MRI is not an X-ray. The basis of MRI are radio waves. Magnetic resonance imaging or nuclear magnetic resonance imaging creates images. Okay, but the technique uses a magnet to align nuclei of atoms inside of the body in a magnetic field. You see it on the next slide. If you put your body in a magnetic field, your atoms align in this magnetic field, and the computer can make pictures out of it. These pictures are so good and so so expressive that we can see the anatomy and wall movement very, very clearly without any other structures around it. We see masses as well. We are able to make a stress MRI to see a coronary heart disease, and we are able to make water-weighted sequences to discover an infection of the heart muscle. This is what we see. Normally, we make 4 sequences to see the wall movement and the function and the anatomy. This is the 4-chamber view. This is the 3-chamber view, 4-chamber because left and right atrium, left and right ventricle. 3-chamber view because of left atrium, left ventricle and aorta, left ventricle outflow tract. This is a 2-chamber view, left atrium, left ventricle, and this is what we call the short axis. And you see overall a good wall movement. You see a normal wideness of the ventricles and atriums. Everything, you see no pericardial effusion. Everything is okay. But here you see a very, very or a bigger wall movement, a bigger wall of the left ventricle here, more muscles. The dimensions of the muscles in this slide are normal and normal configured under 1.2 centimeters. And here you see a very, very imposant left ventricle muscle here as well, and here on the short axis too. This is what we call an HNCM, an hypertrophic non-obstructive cardiomyopathy, and what we see here is an auto-TASH. Does anyone know what TASH is? It's a kind of intervention, cardiological intervention. It's a technique to inject alcohol in coronary arteries to reduce muscle. If obstructive cardiomyopathy occurs and we are not able to reduce the muscle, then it might be that we inject alcohol in the septal branches of the left anterior descendant to reduce muscle. And in this case, the TASH occurred by itself. The hypertrophy of the muscle compressed the vessels and caused infarctions. You see the infarctions here. Wait a minute, or wait 10 seconds. Here, the white spots you see here, or here, are in this sequence, it's called late enhancement or myocardial delayed enhancement. These white spots are infarctions. The black is muscle and the white is scar. You can see it in this sequence. What you see here is a perimyocarditis. Does anyone know what this is? Probably yes. If you got a flu or an infection of your bronchial system, a sinubronchitis, and the flu takes longer than normally, more than 1 week, more than 2 weeks, the risk for a myocarditis is about 40%. Nobody knows that, but the dark number is quite high. The risk is about 40%. And what you get first is an edema in your left ventricle muscle, and you see the edema here is a white spot on this black blood sequence here. And this person had, you see it here in the late enhancement, a scar as well. This is a patient, a young patient with myocarditis after a bronchitis or something, after a flu over 2 or 3 weeks, with a scar as an infarction caused by myocarditis. So what you see here is what we call a swinging heart. If you have a myocarditis or an infection of the heart, you get a pericardial effusion sometimes. And this is a big one. You see the heart swinging in this effusion, so we call it swinging heart. In Germany as well. What do you have to do with it? Puncture. Okay, that's right. And what do you do with the fluid of the puncture? Send it to? To the lab, yeah. And to? What do you want to know?
What kind of fluid?
What kind of? What kind of fluid it is? Yeah, correct. Or tumor. You send it to the pathologist as well, if you can, okay? You do not actually know what happens. You have to make a puncture because you see the right ventricle compressed by the effusion, and it's hemodynamically necessary to reduce the effusion, so you have to puncture it, and you send the fluid away to the lab and to the pathologist, okay? What do you do with a patient with myocarditis clinically? Does he get an operation? Do you send him to a gynecologist?
When the myocarditis is caused by the flu and it's bacterial, you usually give antibiotics.
It's viral over 90%, over 99%, so it's normally not bacterial.
So he does have to rest a lot of time.
Yeah.
Just lay in bed.
Yeah. The only therapy is rest. In former times, we made punctures of myocardium and something like this, and gave them interferon or something. It wasn't useful. So the only thing we do is to give them a rest. They have a rest of about 2 or 3 months. We have to control the MRI every 4 till 6 weeks, echoes in between, and so on. And he has to have rest, okay? Oh, sorry. This is what happens if a myocarditis patient doesn't rest enough. He gets a dilatative cardiomyopathy. You see the heart, here the left ventricle, but the wall movement isn't very strong. It's an ejection fraction under 35%, under 30%, and this is not a nice disease because of what? What kind of problems do you get if you have a heart like this? Hypoxemia. Yeah, but you can't ask a patient outside, do you have hypoxemia? What does he feel? Fatigue, okay. Students are fatigued as well. Hypotension, yeah. But what's the main problem? Yeah, dyspnea. It's the main problem. This person is climbing stairs and can't do that because of dyspnea. This is what clinically occurs. And on the left-hand side, I made a perfusion, a stress perfusion. I didn't see any coronary heart disease, but no, of course, this patient has to go to a cath lab as well. So what we see here, what we can do in cardio MRI is to see whether a patient has a right perfusion of the coronary arteries or not. And there is a special sequence we use, and we give a special medicine. It's called anadozin. And anadozin is a medicine which makes the coronary arteries wide, which makes the pulse fast, and which makes stress. And we want to see what happens in stress. And if a patient has a malperfusion of any region, we see this black spots in the left ventricular walls. This is anterolateral, the anterolateral wall. This is the inferior wall. And this is with movement. You see here inferior. Yeah, you can see it. Probably it's not that good, but you see a black spot here, and here, and here, and you see that is a malperfusion. You see it here, the black spot. Yeah, and this means this person has a malperfusion because it is inferior. It will be the right coronary artery. This person has to go to the cath lab and to get a catheter. Okay? Okay, this is an inferior or posterior infarction. What do you see if you look at this image here? You see the wall movement. This is anteroseptal, this is apical, and this is inferior. And you see a leak of movement here at the basis of the inferior wall. Do you see that? The corresponding late enhancement, that is the sequence where we can see scars, is here. The black is intact muscle, and the white is scar. Yeah? And you see with this disturbed movement, the corresponding scar at this side. In the short axis, you see the disturbed movement here at the basis, here. It doesn't move correctly. And the scar, the white scar, here. Okay? Yes. This is an example for a posterolateral infarction. You see the scar here and the three-chamber view on the posterolateral wall, and here on the short axis. And this is an anteroseptal infarction. It's a small one. We made echo, we made MRI, and we found a small infarction because of the disturbed wall movement of the apical wall here. But in late enhancement, we see the scar is much larger than we thought it is in the Fiesta, in the moved film. You just see a bit disturbed wall movement apically, and here it's much larger. And if you have the right patient, you can see the coronary arteries with a 1.5 Tesla machine. And what you see here, this is the LAD stenosis, this is the left main branch, and the LAD here, and here you see a stenosis. This is the right coronary artery, but this is very hard to find because the patient may not be thick, must breathe optimally, and so on. We see it very seldom.
I have a question.
Yeah.
Was this found accidentally? Because if you usually would have like I don't know, a patient where you suggest the stenosis in the coronary arteries, would you do angiography or would you prefer this procedure?
In cardio MRI, it's not really possible at this time to see the coronary arteries because the heart has three dimensions. It's moving and you are breathing, and that is too much for the computers. In Varna, you have a 3 Tesla machine with better computers, and they work on it scientifically to find it. I don't know. The patients I get are that what we get from the street, and these patients are not the optimal patients. They do not breathe normally. They are too thick. They drank coffee before it. They got a beta blocker or something. They are not the optimal patients. But if we get one, we try to see the coronary arteries. But you cannot seriously measure something on it. Yeah, it's scientific. It's fun. What we see here is an apical infarction. You see the late enhancement here. Left atrium, left ventricle. You see the scar here, and this small black spot here was a thrombus. You see it in the wall movement here. In the Fiesta, you see the infarction here. The movement is disturbed very much. And you see here a small black spot, and we wanted to know whether it's a thrombus or not. And the best way to find it out is to make the late enhancement. And you see it here right in the apex. This is a patient, it was a judge, a very kind man. He's dead. And he had a septal and inferior infarction. You see the 4-chamber view. You see that something is wrong in the septum. This is a septum between the left and the right ventricle. And you see something doesn't move at the septum. You see the short axis. You see the inferior wall and the problems at the inferior wall at the same patient. So this one has an infarction at the septum and at the inferior wall. And in late enhancement, we see these scars here. The white thing is the septum, and inferior, you see it here, it's the white thing here at the inferior wall. So this was a patient with an inferior and a septal heart attack. He survived that, but he died on the road to Switzerland 2 years ago in a restaurant, on the toilet in the restaurant. This is an MRI of an anterior and posterolateral infarction. You see disturbed wall movement anterior and posterolateral. And this is an infarction of the anterior and posterior wall as well. And you see here in late enhancement the scars. The white lines are scar. It's a severe disease. This is an aortic insufficiency. You see it in the 3-chamber view. See the banner of reflow here. And this is a stenosis. In the short axis, you see the Mercedes star here, but it doesn't, the valve doesn't open correctly. And for the heart, it's the problem to pump the blood through this calcificated or narrow valve. It's stress, it's much work for the left ventricle. What does the ventricle do during the first years in patients with an aortic stenosis? If you go to a gym and you pump, what are your muscles going on? Yes? Yeah. The first, what happens is that you get an hypertrophy of the left ventricle muscle, and later it gets dilated, and that's the problem. The chance for the patient is to make an operation before dilatation begins. It depends on the cardiologist. You have to see him every 6 months or something, and when he gets problems, what problems does an aortic stenosis cause? Syncope. Pardon me? Yeah. And angina. Dyspnea, angina, syncope. Yeah? What's syncope in English? Syncope. Okay. That's easy. Okay. Mitral pulmonary insufficiency, it's always the same. What you see here is mitral insufficiency and pulmonary insufficiency. Here, small banner for free flow. And okay, what we must say is that cardio MRI is not the right method to evaluate the valves. If you want to evaluate valves, you have to use echo or TEE, transesophageal echo. You see the valve sometimes, you can see an insufficiency, but you cannot see, you cannot evaluate it seriously. This is a patient with an ASD, with an atrial septum defect. You see it right here. This is the left ventricle, right ventricle, a bit effusion, and this is a hole in the atrial septum. You see in a bit flow from the left atrium to the right atrium. It has a left-right shunt, and this is a ASD. And this, I got it from someone, I don't know what. That's a fetal heart. Nobody would make MRI with a pregnant woman. I don't know why they did that. I don't know, but this is a fetal heart. It works, and this woman is pregnant. It's a classic contraindication to make a MRI with a pregnant woman. Okay, what we see here are masses in the heart. You see here myxoma and a bit effusion here. And this is a benign tumor of the heart. It's called myxoma of the left atrium. Here, these are different patients. And this patient has bigger problems because the myxoma has a prolapse through the valve and really has to be operated as soon as possible because he gets hemodynamic problems. You see an obturation of the left ventricular outflow tract caused by this myxoma which lies on the anterior part of the valve. This is a right atrial thrombus. This is left ventricle, left atrium, right ventricle, and you see this mass here inside of the right atrium. We didn't really know what it was. We thought it was a myxoma as well, but it wasn't. The patient has been operated. The patient had a thrombosis of one leg. The patient had no lung embolism at that time, but had a high risk because of this thrombus. It was operated at least, and we sent it to a pathologist, and it was a solid thrombus caused by a thrombosis of the leg and so on. Therapy is anticoagulation, of course. This is a left ventricular hemangioma. A hemangioma is a benign tumor. Of course, we didn't know what it was. We just saw the tumor in echo, and we made an MRI, and the patient got the operation, and the operation said it was a hemangioma. Yeah, this was critical because it was a renal metastasis of a renal carcinoma in the apex of the right ventricle. The patient died not like long time afterwards. If you have metastasis in your heart, it's a very late stadium of your disease, and you don't survive very long after it. What you see here is an aortic dissection. On the left-hand side, you see an aneurysm of the aorta ascendens right here. And on the right-hand side, you see the dissection. The white part of the vessel is the normal aorta, the normal artery, and the membrane of dissection is right here. The entrance is here, and the gray scheme you see here is thrombus in the dissection. Yeah, here you see an aortic isthmostenosis. If you make cardio MRI, you see all the vessels, and sometimes you see, like, you make an MR angiography, and you see if you want to see whether a person has an aneurysm or something. And this was a finding we didn't expect, that he had a isthmus stenosis. And this is pulmonary artery angiography on the left-hand side. This is your brain on the right-hand side with all your arteries, and on the left-hand side your heart, your arms, subclavia, down to the renal arteries. It's a nice method I wanted to show you, and for the patient, it must be a nice examination, because it doesn't take too long. He has no pain, and he has no risk because of X-ray or something else. This is MR angiography of the renal artery. So on the left-hand side, you see a stenosis of a renal artery over there. And this is the third thing we want to talk over, is the heart catheter. This is our lab in my hospital. This is a table we use, or you use, for your equipment. Normally we have 3 catheters. This one is what we call a pigtail, and you too, a pigtail, because it's like a tail of a pig. This is for the left coronary artery, this is for the right one. And the technique is a Seldinger technique. You find an artery, you have your material, you bring it in your artery, and normally we use the femoral artery or the arteria iliaca or the right radial artery to make the catheter. These are normal findings of the left coronary artery. What you see here is the main branch and the RCX and the LID, which divide shortly after the main branch. Normal findings, no stenosis. The following is the right coronary artery. Normal findings, no plaque. And this is the left ventriculography. I don't know whether you use it very often. We don't. We do not make it very often to save contrast substance. But in former times, we made it quite often to see the function. But echo or something else is much better than the left ventriculography. And what we do if we find a stenosis is a dilatation. We take a wire, and with the wire we go through the stenosis, and then we implantate the balloon in the stenosis, and then we insufflate the balloon, and the stenosis, yeah, you see it like here. We wire the stenosis, we bring the balloon in position, we implantate the balloon or the stent, and this is the result. This is a stent. This is a stent in the vessel. And now some examples follow with interventions. You see the RCA constriction right here. It's over 80%. The patient had angina. We wire the vessel. The wire goes down up to here. And we use this wire to put a balloon to the stenosis. We inflate, we inflate contrast and sodium chloride and make a pre-dilatation. Afterwards, we bring the stent balloon in position. We inflate the stent balloon, and this is the result after ballooning and stenting the RCA stenosis. So we have a optimal flow in this vessel. What we see here is a LAD occlusion on the right-hand side, but additional to that, highly RCA constriction, and the problem of the patient was the RCA constriction here, and this one, the LAD occlusion was older, and the important thing was this here, and we had to do that at once. We made a direct stenting here, and you see the result on the other side. Normal stenosis here. This is a bifurcation stent with kissing balloon. I did it 2 days ago on Tuesday, or Monday or Tuesday. We had a patient with a coronary heart disease of all the 3 vessels, but the main problem was here. It's see it very hardly. It's a short stenosis here, right here, and the rest what you see are pacemaker, ICDs, and so on. And you see the right vessel here. It's a small one, diffuse, sick. It's but the main problem was the bifurcation of the first diagonal branch of the LAD and the LAD itself. And we wired both vessels, the LAD and the first diagonal branch, pre-dilatation of the LAD. The problem was that the LAD and the proximal LAD and the diagonal branch had already a stent, so we had to go through the struts of the stent, made a pre-dilatation, and afterwards the stenting of this vessel followed, but afterwards we had to make a kissing balloon. That means that we have 2 wires with 2 balloons and inflate contrast and sodium chloride in one time, and that's what we call kissing, because the 2 balloons are kissing themselves. And this is the result. You do not see anything, but the stent, it's like a trouser. It's like a culotte stenting. It wasn't a culotte stenting, but it's like a trouser. You see the stent, the scheme of a stent here. Do you see it?
I have a question.
Yeah.
How high is the pressure of the inflated balloon?
Yeah, I wanted to ask that you. Hi. How much pressure do you need for your car?
You need very much more. a high amount.
How much do you need for your car?
I only know for my motorcycle I need 2.2.
Something 2.2 something. Yeah, and in your heart, what do you think? Yeah, more is right. How much? 4 times. Pardon me? That means 8. It goes up to 20, 22 bar. Yeah? Normally 10 bar, 12, 14 or something. These two balloons, both of these two balloons had 18 bar. It depends on the stenosis, whether it's calcificated or not. You have a feeling for it. You see what happens in the vessel, and you see long, some seconds, yeah, 4 or 5 seconds. For this we needed 18 bar for this kissing. What you see here is an occlusion of the right coronary artery, acute infarction. On ECG you see the ST elevation in 2, 3, I don't see that, and AVF normally. And in the right coronary you see the obstruction here. You don't see the vessel. The vessel ends here. Normally it goes round like this, but here it was finished. And what we make normally is to wire the vessel. You see the wire here on the right-hand side, and then we wire the whole vessel, and we get a bit perfusion because of the wiring, but the problem was here. And then followed something like, we made something like a full metal jacket. The vessel had problems in all parts, so we had to make a pre-dilatation of the whole vessel and a stenting of the whole vessel. And afterwards we had this result. This is before stenting, this is afterwards. It's nice, isn't it? Yeah.
Is this the same imaging you used while doing it?
Of course. The same patient, same imaging, the same. This is with a fresh infarction, and this is 35 minutes later. This is an intervention with an anterior ST elevation infarction. You see the LAD, the left anterior descending, and the high-graded stenosis. Here it's over 99%. We wire it. It's always the same, so you can say cardiology is boring, but we wire it. We wire the whole vessel. We make a pre-dilatation normally. We make the stenting, and this is the result. This is an intervention with an NSTEMI, that means non-ST elevation. You haven't got the typical changings on ECG. And we see a RCX construction here, very peripherically. We position the balloon, wiring, position the balloon, stenting, result. This is a severe disease, critical disease, constrictions of the main branch. If you remember the model, you have the LCA, the left coronary artery, with the main branch here, and with the bifurcation with the RCX and LAD here. And this main branch has a critical stenosis here, and that is very dangerous because the patient gets an infarction. Anterior, LAD, and lateral, RCX, and he goes dead, okay? Normally you do not survive this if you get an infarction. So we had to be a bit faster. We put 2 wires in the LAD here and RCX here, made a direct stenting, and this is the result. It takes about 20 minutes, but it was necessary. And this one was a patient we got from our vascular surgery right after an operation. We had to make it over the arteria radialis on the right-hand side, because the operation was an epsilon protesis, a Y protesis in the legs. And we saw critical stenosis of the main branch here. And the problem was that the main branch of this person, he came from not Bulgaria, something nearby. He was a driver of a truck. And the problem was the catheter was larger than the ostium of the left main branch. So I couldn't get in the ostium with my catheter. You see the constriction right here. The patient was in CPR. It was intubated, and we got it in the cath lab with reanimation. So like this. So we had to work with this movement all the time. It was a bit more work for us. We positioned a guiding catheter, and I've been able to position a wire in the LAD, and we made a direct stenting, and this is the result. So the person survived it, could be extubated 2 hours later, but I saw him smoking 2 weeks later on the balcony, but it doesn't take long, I'm sure. And this is a case of a person who has to get a bypass operation. You can make an intervention in the most coronary problems, but not in all. And this woman had problems at the right artery, and LAD, RCX, we had to send her to bypass operation. That means to a university hospital to get a bypass. That's it. Thank you very much.